Welcome back to Chapter 16 for Community Health Paramedicine. This next chapter focuses on mental health. This is one that is very near and dear to me. I know I shared with you guys in the classroom that I was one of the babies that grew up in the drug homes that saw a lot of things that I probably should not have seen, and a lot of that had to do with mental health from my parents. So after meeting you guys, I know that a lot of you feel the same about mental health, and how we look at it is definitely needs a little love and adjustment. So we're going to jump right into our community health lecture on Chapter 16, Mental Health. One of the greatest challenges you will face as a community paramedic is the close relationships that you have between medical illness and psychiatric disorders. At the time of dispatch, roughly 2/3 of 911 calls are for medical situations, and roughly 1/3 are for psychiatric and behavioral issues. The more we learn about our patients, the more likely we are to see that the patient's mind and body are inseparable. They are parts of the whole person. A patient with diabetes may have a major depressive disorder that impairs their ability to comply with insulin management. A patient with schizophrenia may be experiencing involuntary muscle contractions after starting a new medication to manage their hypertension. As a CP, you have the advantage of having significantly more time to perform a detailed patient assessment and develop a professional healthcare relationship with the patient. Taking your time is important when you deal with psychiatric disorders. You will work to navigate the patient towards self-care as well as management. So let's jump into a little history about mental health. So back in ancient times, a negative viewpoint of mental illness began with ancient Chinese, Hebrew, Egyptian, Greek, and Roman societies. They associated psychiatric disorders and abnormal behavior with evil spirits and demons. People affected by psychiatric disorders were deemed possessed, and emphasis was placed on a lack of morality and character. Unfortunately, people with psychiatric disorders today are still subjected to negative moral judgments. Example, a person who is homeless and sitting on the corner, muttering, unkept, possibly in the midst of a schizophrenia crisis, is all but invisible to passerbyers. Moral judgment is still evident with patients struggling with alcohol and drug addiction, who may be viewed by some in society as lacking in willpower. So the Australian neurologist Sigmund Freud, who was born in 1856, was intrigued by the causes of behavior in humans. His ideas changed how personality development is viewed, and how inner psychological conflict is discussed and how it's treated. Freud held that we have distinct levels of awareness about our external and internal lives. Beyond our conscious mind, there is a deeper layer to who we are, a vast storehouse of memories, feelings, daydreams, fantasies, hopes, fears, and experiences. This information is often filed away before we develop mature, rational minds, or it's absorbed so quickly during a traumatic event that we do not have adequate time to process the emotions. Freud believed this information resides in the unconscious mind, which can be assessed or accessed only with a great deal of effort in therapy or during dreams when the rational mind is not engaged. An example, the military veteran who has returned from combat deployment may access the unconscious mind during flashbacks and distressing nightmares as his or her mind works to process the trauma of the war that they've seen. Freud's works marks the birth of modern psychology and offers a window of understanding into some of the most complex psychiatric disorders. Modern research in neurophysiology, brain imaging, and genetics has expanded our understanding of the mind. The areas of the frontal lobe are responsible for executive functioning, or what we sometimes call the rational mind. These areas mediate our emotions, control our judgments, monitor our behaviors. The temporal lobes help to control and process our sense of hearing and place regulatory roles in speech. Functional magnetic resonance imaging, or MRI, of the frontal lobes and temporal lobes of patients with schizophrenia show hyperactivity when compared to MRI of the brains of patients without schizophrenia. This hyperactivity may help to illuminate why the hallmarks of schizophrenia include disordered thinking, auditory hallucinations, and disorganized speech. Until the 19th century, the U.S. followed Europe's pattern of housing persons with psychiatric disorders in asylums, jails, and poorhouses. Following investigations of the inhumane and uncivilized treatment of patients in asylums, activists led efforts to establish psychiatric hospitals dedicated to the professional care of patients with psychiatric disorders. By the late 19th century, all of the asylums were closed and dedicated psychiatric hospitals were built across the United States. That emphasis on treatment has since been reversed. Jails and prisons now play a central role in the contemporary response to psychiatric disorders. By 2016, psychiatric beds numbered only about 35,000, and 10 times more patients with psychiatric disorders were in prisons than in state hospital beds. The driving force behind the dramatic shift can be summed up in one word: deinstitutionalization. There, that one's for you, Ryan. Following the discovery of Thorazine and other antipsychotics in the 1950s, public policy shifted to emphasize the use of medications and in-community treatment. Mental health and healthcare professionals are familiar with the difficulty of finding inpatient care for the revolving door patient who is socially isolated and requires help with addiction, psychiatric disorders, and underlying physical illness. Finding ways to make effective treatment referrals and to ensure an integrated part of care for patients with psychiatric disorders is among the most difficult challenges facing community paramedics in the field today. Behavior is defined as the way a person acts or responds outwardly, the patient's activities that we can observe. Community paramedics must be careful to not make premature conclusions about their patient's internal life from the external signs they present. It can be difficult to tell, particularly when a person is in crisis, if the cause of abnormal behavior is maybe stress, a medical illness, the use of alcohol or drugs, or psychiatric disorder. As experienced emergency medical services providers, community paramedics are familiar with the confusion experienced by a patient with diabetes whose blood glucose is too low, or a patient who's consumed too much alcohol or mind-altering drugs, or the patient with Alzheimer's. The threshold for identifying a psychiatric emergency is based on the level of agitation, violence, or uncooperative behavior that poses a threat to self or others. The safety of any scene can deteriorate rapidly, and a patient's condition can change rapidly, certainly from visit to visit. As a community paramedic, you need to be alert to the signs of intermittent behavioral change and even violence. Chronic psychiatric disorders tend to persist over a long period, in some cases for the entire lifespan of the patient. Although most psychiatric disorders have the potential to become chronic, the chronic psychiatric disorder that community paramedics are most likely to encounter includes schizophrenia, major depressive disorder, bipolar disorder, and OCD. The patient's chronic psychiatric disorder may not be evident or present all the time. Treatment options for the patient with a chronic psychiatric disorder may not be readily available because of the lack of resources, or prohibitive cost, lack of accessibility, or limited program capacity. We classify psychiatric disorders based on definitions of the signs and symptoms of their abnormal condition. These definitions are continually tested, debated, and revised through scientific research to incorporate new evidence. The result of this effort is the Diagnostic and Statistical Manual of Mental Disorders. It's now in its 5th edition. This nearly 1,000-page work is published by the American Psychiatric Association list in common language all psychiatric disorders, along with these. So this is nearly 1,000 pages. It has all the list of symptoms, descriptions of the disorders, and the criteria for the diagnosis. It is a good handbook if you want to go pick this one up. I'm not sure of the cost, but it is something that you can pick up on Amazon if you are interested. So causes of psychiatric symptoms, signs and symptoms that appear to signify psychiatric disorders such as hallucinations may sometimes be the result of a medical condition. Because of the psychological effects of medical disease that can produce or mimic psychiatric disorders, it's important to treat the whole person, the mind, and the body, rather than this simply assuming the problem stems only from the patient's mind. Start by taking that thorough medical history and performing a physical examination of the patient. Recognize that a psychiatric disorder may be non-symptomatic at the time the first patient assessment happened, as some psychiatric disorders develop slowly over time. During the interview, ask the patient about psychiatric disorders and any past treatment that they've had. Signs and symptoms that imply an emergent medical condition as the primary driver of a psychiatric disorder and require activation of EMS for rapid transport include loss of memory, severe headache, muscle weakness, and heat intolerance. It may also include sudden onset psychosis, abnormal vital signs, slurred speech, and seizures. You should suspect a medical cause if there has been a rapid onset of memory loss and psychosis. Safety concerns are definitely always a biggie that need to be front and center. Most patients with psychiatric disorders are not violent. The lifetime prevalence of violence among people with serious psychiatric disorders is 16%, compared with 7% for people who do not have psychiatric disorders. Substance abuse, by contrast, can greatly increase patients' propensity for violence. Predictors of violence include a past history of violent behavior, a history of childhood abuse, borderline or antisocial personality disorders, substance abuse, factors such as young age, male sex, and lower socioeconomic status. Violent outbursts often follow a recognizable pattern of warning signs, so be on the lookout for these. Fixed, staring facial expressions, clenched jaws or fists, rigid, intense posture, loud and threatening speech, escalating verbal profanity, and unusual restless pacing or motor hyperactivity. Aggressive motor activity is a red flag for impending violence and requires immediate intervention and management. Follow your local protocols and always remember BSI, being safe first. To reduce the likelihood of violence, the community paramedic should take the time to create an atmosphere of safety, extend respect to the patient, and work hard to establish trust. The assessment for suicide risk is also something that we do need to do and make a part of our plan. So suicide is a major health problem, representing the 10th leading cause of death in the U.S. in 2013. In that year, 41,149 suicides occurred in the United States at a rate of 12.6 deaths per 100,000 people. That's equivalent to 113 suicides every day. Risk factors include seriousness of previous attempts, history of attempts, suicidal ideations. Additional risk factors may be chronic deteriorating medical illness, inability to maintain a job, feelings of worthlessness, or recent onset of impulsive behavior. So the following practice can potentially improve the quality of your assessment and treatment of people at risk for suicide. So suspend your moral judgment, establish trust, talk openly, frankly, and objectively with the patient about the topic. Don't tiptoe around it. Stay on topic. Be aware of psychiatric disorders where suicide risk factors were in the diagnostic creation of the disorder, and offer assistance. Stand with them and meet them where they are. Substance abuse, also called chemical dependency, is a medical terminology used to describe the use of psychoactive, mind-altering substances that result in the physical or psychological addiction accompanied by recurrent and significant consequences. CPs may encounter patients with dual diagnosis, meaning the presence of both a substance abuse disorder and an underlying psychiatric disorder. Virtually all health professionals agree that alcohol and drugs abuse and dependency must be treated first. Therapies and interventions must wait until successful completion of chemical dependency treatment has occurred. So assessment of substance abuse, wait to assess the patient until they are sober, while closely monitoring the patient's medical symptoms. If the patient's mental status is altered at the time of assessment, we should arrange for transport to detox or reschedule the patient assessment for another home visit, whichever is applicable. As part of the assessment, we need to obtain a complete alcohol and drug history. That includes the type of substances, how long they've been using them, previous hospitalization for substance-related conditions, consequences of use, any prior treatments or periods of abstinence. Tests to determine if substance abuse is a problem. We have the CAF test, and then our alcohol use disorders identification test, or better known as audit. So referring the patient who is substance dependent to seek help or treatment is an art, because patients with patterns of substance abuse become skilled at minimizing as well as rationalizing, projection as well. They're great at blaming others. The community paramedic can appeal to a desire to recover even if the patient may have failed in previous attempts at sobriety. Reaffirm the work. Let them know their worth and their ability to recover, and it can help to reduce denial with that. Challenge the patient by using the patient's own input about how he or she sees the problem or how they may have described it in the past. Give encouraging feedback. Explain the precipitation and treatment is the patient's responsibility, but the patient is not responsible for the disease. Some programs have open meetings or beginners group that welcome people seeking an introduction to the recovery model of the 12-step program. AA or NA, Alcoholics Anonymous, and Narcotics Anonymous. So success in moving a patient towards therapy for addiction can be a trial and error process, and it generally is. Success requires a degree of motivation on the part of the patient. They have to be there and be ready. An umbrella of safety from you or the counselor or the therapist. Good timing to exploit opportunistic moments when the patient is compelled or legally ordered to seek treatment. Primary versus secondary psychosis. So let's talk a little bit about that. Primary versus secondary. CPs may encounter a patient with psychosis at any time on a routine visit for follow-up care, at time of first patient encounter, as needed to meet the waxing and waning needs of a patient with a major psychiatric disorder. The cause may be an underlying medical condition, UTIs being one of our biggies, or medication side effects as well. The general meaning of psychosis is impaired reality testing, which means that the patient is unable to clearly distinguish external reality from their own internal reality. Primary psychosis is a serious psychiatric disorder that is characterized by impaired thinking and emotions that causes the patient to lose contact with external reality. The patient may exhibit delusions or thoughts that are blatantly false, or experience auditory, visual, tactile, olfactory hallucinations as well. Psychiatric states may, but do not always, manifest as disorganized speech, a heightened level of agitation, paranoia. One of the most significant of these psychiatric disorders is schizophrenia. Secondary psychosis refers to psychotic features caused by medical illnesses, substance abuse, or medications. In these cases, the patient may not necessarily have an underlying psychiatric condition. The following guidelines may help distinguish psychosis arising from a medical condition or pharmacological influence from that arising from an underlying psychiatric disorder. The patient has an underlying medical condition previously diagnosed that is currently symptomatic. There is a proximal time relationship between the medical condition, recent onset, exacerbation, or remission, and psychiatric symptoms. The patient or the signs and symptoms of the psychosis are atypical, meaning they're unusual for a patient of this age to occur. So seek direction from your medical director if your patient presents with psychiatric symptoms. Schizophrenia, it is unknown what causes schizophrenia. It generally manifests prior to the age of 25. So the range of onset is 16 to 30 years of age and persists for the rest of the person's life. Development of schizophrenia may be affected by genetics, the environment, or even neurotransmitters. There is no single marker, such as a blood test, that identifies schizophrenia. Rather, this disorder presents with a broad clinical picture. So how do we diagnose it? The DSM-5 criteria requires the person experience 2 or more of the following 5 symptoms for at least 1 month to warrant a diagnosis of schizophrenia: delusions, hallucinations, disorganized speech, disorganized or unresponsive behavior, negative symptoms such as flat affect or decreased motivation. Other factors considered in the diagnosis include deterioration of ability to maintain a job, interpersonal relationships, and self-care. At the center of the symptoms of schizophrenia is disordered reality testing that is worsened by periods of delusions as well as hallucinations. Treatment of schizophrenia is frequently viewed as consisting of 3 phases: acute, stabilization, and maintenance. Ruling out suicide risk is in the acute phase, and it is very critical. Medication therapy remains the cornerstone of schizophrenia management throughout the course of treatment. However, it is very hard for schizophrenic patients to remain up to date and current with treatment. Combining medication therapy with psychosocial therapy helps prevent relapse. Coordinated specialty care has been shown to improve treatment outcomes for young people with early-stage psychosis. First-generation antipsychotics, now called our typical antipsychotics, are still used to treat schizophrenia. The effectiveness, though, is debated. Compliance rates are low, about 30%. There could be extrapyramidal symptoms and tardive dyskinesia. Second-generation antipsychotics, now called atypical antipsychotics, may show modest benefit over first-generation medications. There's fewer side effects. There is a risk of weight gain with those medications, though. CP should monitor and keep a record of adverse effects from schizophrenia medications such as sedation, difficulty sleeping, sexual and reproductive system problems, extrapyramidal symptoms, weight change, abnormalities in blood pressure, changes in blood lipid and glucose levels. Although schizophrenia is not curable and relapse rates are high, patients do experience periods, sometimes long periods, of remission or improvement. Relapse rates remain high, up to 82% after 5 years. Discontinuing medication is associated with a 5 times higher risk of relapse as compared to staying on medication. Ongoing psychosocial assessment is important for all patients with schizophrenia. When appropriate and if available, enlist concerned family members in the assessment and care of the patient as well. On to bipolar. Bipolar disorder is an example of how our understanding of psychiatric disorders can change over time. This disease was formerly called manic depressive disorder, a term that implied the patient experienced periods of exuberant euphoric hyperactivity and racing thoughts, those manic episodes, which were then routinely followed by down periods of depressed mood, lack of interest in activities, and thoughts about death, the depressive episodes. In reality, patients may have numerous periods of major depression before the first episode of mania occurs. Moods can cycle in highly variable ways in frequency and severity. Bipolar disorder is the 6th leading cause of disability in the developed world in people 15 to 44 years of age. Our bipolar disorder is frequently associated with other coexisting conditions, most commonly anxiety disorders and substance abuse disorder. In addition, many common medical illnesses can cause or influence the symptoms of bipolar disorder. It's vital to assess the patient with bipolar for risk of harming themselves or harming others. Bipolar disorders can be confusing because the disorder is divided into 2 distinctly separate illnesses, bipolar 1 and bipolar 2. Bipolar 1 is roughly equivalent to the historical definition of manic depressive illness, placing an emphasis on episodes of severe mania followed by that period of depression. Bipolar 2 requires at least one major depressive episode and hypomania, which is a lesser degree of mania, but emphasizes impairment at work and social functioning caused by depression. Depending on the CP program, the goal for community paramedics when assessing a patient with suspected bipolar disorder is to look for core symptoms of both disorders and generally judge which aspect of bipolar disorder is causing the patient greatest harm. The community paramedic should seek direction for an appropriate referral to the ED or psychiatric consult in accordance with their local protocols. So therapeutic interventions, the primary role for us working with a patient with bipolar may be monitoring medication compliance, monitoring potential substance abuse, and helping to ensure adherence to the patient's psychotherapy treatment plan. A first priority for the patients with bipolar disorder is an assessment for substance abuse and dependency. Patients can achieve greater control over mood swings through a combination of medications as well as psychotherapy. Mood stabilizers are the first choice for treatment. Most commonly is lithium. Because bipolar disorder is a complicated disease, other medications are brought into the treatment protocol as necessary to treat psychotic and depressive symptoms. So patients' education and counseling include psychotherapy, cognitive behavioral therapy. They're typically added as components to treatment after the initial stabilization has occurred. A relatively new protocol, interpersonal and social rhythm therapy, or IPSRT, seeks to help patients stabilize routines for sleep, meal times, and exercise, because they are all linked to general disorders. Depressive disorder. Depression is a disorder of the mood. It is characterized by extreme sadness, irritability, loss of the ability to experience pleasure. It is accompanied by fatigue, disturbances of sleep, appetite, as well as sexual desire. The primary emotion experienced by persons with depression is profound sadness. There may be no external reason for the feelings of the profound sadness as well. Depression can occur later in life, even in people who have not previously experienced a depressive episode. Major depressive disorder occurs in 5% of adults older than 60, and as many as 16% of these adults have clinically significant depressive symptoms. Rates of the disorder rise with the presence of coexisting medical conditions and increase dramatically after hospitalizations. CPs may need to refer an older patient for assessment of cognitive deficits that can, by themselves, increase levels of clinical depression. The challenge with our older patients is to assess the impact of coexisting illnesses. While suicide assessment is important for our older patients, the risk in this population warrants greater attention and precaution. The CP should look for changes in normal patterns and closely monitor the older patient's pattern of social activities, any eating changes, level of worry, sleep habits, and just any general complaints that they may have. For therapeutic interventions, that depends on your program. We may monitor medication compliance, monitor their adherence to psychotherapy treatments, act as a source of support and encouragement to the patient. The two models of treatment have been produced positive results and continue to be cost effective. That would be antidepressant medication and cognitive behavioral therapy. Antidepressants remain the first line treatment for patients with depression. We do need to make sure the patient knows what to expect in terms of response to this medication and potential side effects that they may have and how to manage the start and discontinuation of this medication. Importantly, suicide is a risk with antidepressants both at the start and at the end when they discontinue them. One notable risk associated with the major selective serotonin reuptake inhibitors are SSRIs, antidepressants such as, our Zoloft, our fluoxetine, escitalopram, is serotonin syndrome. This is a serious and potentially fatal condition that is caused by too much serotonin in the neurosynapses of the brain and our spinal cord. So it's in our brainstem and our spinal cord. So other medications can definitely play effect with this. I had a friend who was on Zofran and also took an SSRI and ended up having a major issue with serotonin syndrome and didn't realize that was the problem. So closely monitor your patients that are on SSRIs and what other medications they could also be taking. For cognitive behavioral therapy, the concept of American psychiatrist Aaron Beck of the University of Pennsylvania, this therapy is based on the idea that changing the way a patient thinks can change the way a patient feels, and therefore the way the patient responds. When undergoing CBT, the patient works with a mental health counselor in a structured way, attending a limited number of sessions. CBT can be very helpful with treating a variety of psychiatric disorders such as depression, PTSD, and even eating disorders. CBT can also be an effective and affordable tool to help anyone learn how to better manage stressful life situations. We also have electroconvulsive therapy. This was developed back in 1938. ECT is the oldest form of brain stimulation therapy and has an infamous reputation in popular culture. It is often an effective treatment for depression that has resisted antidepressant medications and other forms of therapy. Following careful medical screening in a highly controlled environment, low energy electrical current is passed through the brain to cause a seizure lasting 1 minute. Common side effects could be short-term confusion, headaches, muscle ache, nausea, and temporary memory loss. ECT has been reported to result in prompt improvement in symptoms of depression in the majority of patients that have been treated. It's not clear why and how it works, but the procedure is considered safe and the patient response is rapid. Usually patients receive treatments 2 or 3 times per week in a series of 6 to 12 treatments. The major drawback of ECT is the relatively high cost that's associated with it. So repetitive transcranial magnetic stimulation may be an option. That's when we have an electromagnetic coil that's held against the forehead and short electromagnetic pulses are administered via the coil. This treatment for depression is relatively new, and response rates and side effects are the focus of ongoing research that is going on right now. Patients report headaches and sensitivity at the site of the head where the magnet was placed, but we do not yet know the long-term effects of this. On to anxiety disorders. For some people, the feeling of fear can become excessive, evolving into a paralyzing dread about some future threat. In other words, anxiety. When anxiety becomes irrational and difficult to control, it is considered a psychiatric pathology if it meets specific diagnostic criteria. Among the many important changes in DSM-5, the types of anxiety disorders and their essential features were reclassified. At the core of general anxiety disorder, GAD, is chronic and persistent worry, a fretfulness that typically centers on numerous issues, whether it's work, finances, health. Patients with GAD have a number of common presenting attributes. The worry is uncontrollable and is consistent for over 6 months. The disorder is often associated with depression, alcohol abuse, and substance abuse. It frequently persists or presents with multiple but often nonspecific symptoms of physical health: back pain, headaches, GI problems, insomnia. Anxiety disorders commonly co-occur with alcohol and drug abuse, which can either mask the symptoms of anxiety or amplify them. During the patient assessment, look for signs and symptoms of depression and post-traumatic stress disorder. Patients should be evaluated for GAD by a mental health professional if they have at least 3 of the following symptoms: restlessness or a feeling of being keyed up or on edge, fatigue, difficulty concentrating, irritability, muscle tension, or sleep disturbances. Phobic disorders are characterized by excessive or irrational fears. Examples could be agoraphobia, which is an overwhelming fear triggered by being outside; social phobia, which is a fear of scrutiny by others, particularly their peers; or specific phobia, marked fear or anxiety about a specific object or situation. It is common for patients with the disorder to have multiple specific phobias. It is helpful in crafting treatment to determine if the specific phobia is tied to a traumatic event. Therapeutic interventions depend on the community paramedic program and the role that you have. May be monitoring medication, their compliance, adherence to psychiatric treatment plans. May also be educating them about the need to keep those appointments. So pharmacology treatment, and most frequently used to treat these anxiety disorders. So psychotherapy and pharmacology combined have the greatest success. On to OCD. Obsessive compulsive disorder is a psychiatric disorder. It's frequently misunderstood by the public. It was previously viewed as anxiety or personality disorder, but is better classified as a neuropsychiatric disorder. Hoarding disorders, for example, is closely related to this. Patients with OCD exhibit obsessions, repetitive, intrusive thoughts, compulsions, repetitive, ritualistic behaviors. Not surprisingly, then OCD has a high comorbidity with depression. Physical and sexual abuse and other traumatic stress have also been associated with OCD. The cause of OCD is poorly understood. We don't really know. Some studies of brain structures have found cognitive deficits and hyperactivity in the frontal lobe. Exposure and response therapy and CBT are the most effective treatments for OCD. Post-traumatic stress disorder, one we are probably very commonly associated with in the field. So it is enormously complex with dimensions of anxiety, depression, dissociation, sleep disturbances, and memory impairment as well. The patient with PTSD commonly re-experiences the event with intrusive recollections, replays, and distressing memories that usually include sensory, emotional, and psychological behavioral components. How and why PTSD develops in patients is not clearly understood. So we may monitor the patient for medication compliance, compliance with their psychiatric treatment, assist in navigating the patient to stable living conditions in a safe physical environment, monitor the patient's physical health and risk of suicide. CPs may navigate the patient to outreach services such as Via Health, the Veterans Affairs, or local support groups within the community. We may help assess pain management, substance abuse, housing, and employment. In general, the following treatments have withstood greater scrutiny through their effectiveness, or though their effectiveness varies across most patient populations. There's something called exposure therapy. Most forms use a therapist-guided recall of traumatic memories in a controlled fashion so the patient can regain mastery of their own thoughts, feelings about the incident. The aim is to help the patient reevaluate and safely return to the activities that they had previously avoided. CBT is frequently used in concert with exposure therapy. CBT revises the patient's thinking pattern and automatic responses. Stress inoculation therapy. This hybrid treatment combines elements of CBT with specific techniques of anxiety reduction, breathing, muscle relaxation, and memory recall. Eye movement desensitization and reprocessing, or EMDR. This treatment combines exposure therapy with a series of guided eye movement. It is not clear how this works either, but it has shown favorable results in treatment of PTSD. So our EMDR, this treatment combines exposure therapy with a series of these guided the eye movements. I did this with my son actually at a younger age, and he had some pretty good success with the EMDR. I think very favorable of this one actually. For medications, both antidepressants and anti-anxiety medications are often used to treat patients with their PTSD. In addition, parazonin, minipress, is sometimes used to suppress nightmares. Our psychotherapy, individual and group psychotherapy, are frequently used to treat patients with PTSD as well, and then also our service animals. Recent trials utilizing service animals to reduce anxiety and calm night terrors have shown great promise. Personal style of dealing with people. So an integral part of the treatment of patients with psychiatric disorders is the community paramedic's personal style of dealing with other people. Your manner of speech, values, beliefs, and the ability to listen as well. It is vital to suspend any judgment of the patient and provide the patient with a sense of emotional safety. Meet them where they are. To help establish trust with the patient, the community paramedic can use a number of techniques, including maintaining cultural sensitivity. In addition, the CP should give respect and make a concentrated effort to earn the patient's trust. The patient will easily recognize when a community paramedic is genuine, when they have compassion, when they view him as a human being. Take your time. Trust evolves over the course of your relationship with the patient. Listen actively and respond rather than react. Focus on what they are saying and respond by paraphrasing it back to them. So what I hear you saying is, above all, do not offer solutions and give advice. Use positive body language and cues. Use direct eye contact. Set limits and stick with them and maintain professional boundaries. Referrals, psychiatric or psychology. The difference between psychiatric and psychology disorders is in many ways established by the means used to treat the disorder. That is, between the treatment based on pills and the treatment featuring skills. The most successful programs incorporate counselors who also address a broad spectrum of medication therapy, individual and family therapy, substance abuse treatment, vocational, housing, educational, social, and nutritional needs. As a community paramedic, you will meet patients or you will meet with the patient alone, yet many patients with serious psychiatric disorders require additional resources. While the medical director or the patient's primary care physician will determine to whom the patient will be referred, as a CP, you may be an advocate for the patient. Discuss the patient with the medical director. The patient may be referred to the following professions or professionals. Maybe medical doctors, including psychiatrists, psychologists, clinical social workers, psychiatric mental health nurses, marriage and family therapists, licensed professional counselors, chemical dependence counselors. As a CP, you may navigate patients to outreach services and assist in navigating the healthcare system, because we all know how easy it is to navigate that healthcare system on our own. Being familiar with the specific agencies, clinics, hospitals, treatment programs in your area, including their availability, accessibility, and costs, is essential for them. Next, identify who will manage the case, especially after the referral is made. And finally, follow up on the referral. That's all I have for you today for mental health chapter. Please reach out if you have any questions. Keep the pace going with completing your task and your homework. We only have one more module before the end of the program in December. Y'all take care, and please don't hesitate to reach out if you have any needs.